Advanced airway management, problems with intubating bougies, the secret life of endotracheal tubes, double lumen tubes. What you see is not what you get. In the early history of anesthesia, before the advent of fibre optic scopes, glide scopes and laryngeal masks, when an intubator was faced with difficulty, his first available option, other than a simple stylet, was the gum elastic bougie. It is an incredibly useful device, but since its introduction, we know that it can cause pulmonary hemorrhage, pneumothorax, and upper airway soft tissue trauma, and this dictates that we use it with the greatest of caution. Laryngoscopes were designed to be held in the left hand. The blade was placed on the right side of the mouth to displace the tongue leftwards, creating a corridor on the right side of the mouth to pass an endotracheal tube. This meant that the endotracheal tube would be held in the right hand and advanced towards the larynx on the right side of the mouth. And recognition of this very simple fact helps us to understand many of the subsequent difficulties we will experience with the use of intubating bougies. Consider the following scenario. After induction of general anesthesia, the intubator performs laryngoscopy, and the best view he can obtain is this. This is a difficult view, but the operator can just distinguish the right arytenoid cartilage. Faced with this challenge, he decides that an intubating bougie may be helpful. He manages to advance the tip of the bougie above the right arytenoid, past the vocal cords and into the trachea. Now, incidentally, at this point, I must make some important observations. Just note that because the patient is a normal-sized male, the intubator plans to insert the endotracheal tube to 23 centimeters and no further. So, gripping the bougie at the 23 centimeter calibration, and when these fingers gripping the bougie reach the upper incisor teeth, he advances the bougie no further because excessive advancement of the bougie can be dangerous. Also note that the presence of the bougie tends to pull the larynx downwards, that is, pulling it posteriorly, to bring the glottic opening more into alignment with your visual axis, significantly improving laryngeal visualization. The intubator's next task is to remove the laryngoscope and mount a conventional endotracheal tube on the bougie and gently but expeditiously deliver the endotracheal tube into the trachea and commence ventilation of the lungs before the arterial oxygen desaturation occurs. Unfortunately, in this case, this is much easier said than done. At approximately 12 to 16 centimeters of insertion, further advancement of the endotracheal tube is met with resistance. Keeping the bougie completely immobile, he withdraws the endotracheal tube slightly and reinserts it multiple times, but each attempt at advancement meets with the same insuperable resistance. Now, time is passing. Oxygen saturations are gradually diminishing. But the intubator realizes he has a major problem. The intubator is utterly certain that the bougie entered the trachea, and he's becoming increasingly frustrated with himself in his inability to troubleshoot the problem. And the thought continuously running through his mind is, what on earth is going on here? Now, the following images of laryngeal anatomy and the position of the intubating bougie in the larynx clearly demonstrate the cause of the intubator's problem. Study them carefully. I refer to this as the end of the endotracheal tube tip being impaled on the right arytenoid. Now, how do we deal with this situation? This illustrates one option to simply displace the intubating bougie leftwards in the larynx away from the right arytenoid. Again, this is easier said than done, but repositioning the bougie in the mouth won't necessarily help. The bougie needs to be repositioned deep in the pharynx. That would mean inserting your index finger of your dominant hand down as far as the base of the tongue and displacing the bougie leftwards. However, a much simpler approach is to re-advance your endotracheal tube over the bougie, giving it a clockwise corkscrew twist as it approaches the right arytenoid. And this technique solves the problem much more quickly than an attempt to reposition the bougie deep in the pharynx. This technique was taught to me by Dr. Paul Cosham, who published it in the British Journal of Anesthesia in the 1980s. And the technique is well illustrated in this little video clip. A common problem when using this technique is that the intubator advances the tube, then stops momentarily to rotate it. This is incorrect and will fail. Advancement and rotation must be simultaneous, allowing the oblique orifice at the tip of the endotracheal tube to slide onto and then off the right arytenoid and into the glottis. If the problem continues, despite good insertion technique, simply attempt an anti-clockwise rotation during advancement. Now earlier, we mentioned the concerns of a prolonged period of apnea leading to arterial oxygen desaturation. As you can see in this video, without advancing or withdrawing the intubating bougie even a tiny amount, this intubating bougie can be gently laid sideways across the patient's face, allowing tight application of an anesthesia face mask and positive pressure ventilation of the patient with 100% oxygen. When the patient is well oxygenated, further attempts at endotracheal intubation can be continued. Now, moving on. Consider this, a second AIRWAY scenario which proceeds in a way very similar to the first scenario. Until we get to a point where, after multiple advancements of the endotracheal tube over the bougie, finally, the endotracheal tube does advance, it seems to pop in, and the intubator inflates his cuff, secures the tube, connects to the breathing circuit, and gently manually ventilates the patient. Initial attempts to confirm bilateral and symmetrical ventilation of the lung fields, however, dismay the operator. He's very disappointed, and when he auscultates over the epigastrium, it has the typical bubbling sound called borborygmi, characteristic of gastric insufflation. The intubator realizes, of course, that this is esophageal intubation, but he is filled with consternation because he actually witnessed the intubating bougie pass through the glottis and into the trachea. Again, What on earth could possibly be going on here? Now, to fully understand this issue, we have to consider the mechanical properties of the intubating bougie relative to the mechanical properties of the endotracheal tube. And also, we need to acknowledge the very close proximity of the laryngeal and esophageal orifices. Again, please turn your attention to these images of the upper airway. These images indicate that the approach to the larynx from the mouth is a short, narrow corridor with its narrowest point immediately posterior to the base of the tongue. And as this corridor is shared with the respiratory tract and gastrointestinal tract, it ends in the laryngeal and esophageal orifices being in very close proximity. These brief videos illustrating the mechanical interaction between conventional PVC endotracheal tubes and some widely available bougies. And I hope you recognize that in the last video, that 15 French gauge Sunmed bougie put up a remarkable fight. Clearly, some bougies are stiff and robust, and others are soft and floppy. This next series of images of intubation over a bougie in an anatomical model illustrate exactly what happened in this airway scenario. And so, for obvious reasons, I refer to this as the flip-out phenomena, as the bougie flips out of the glottis into the esophagus. Now, at this point, I want to put this very practical consideration of managing difficult intubation into a more conceptual framework to facilitate understanding the mechanism by which these difficulties arise. This will hopefully allow us to predict and avoid mechanical problems with intubation in the future. The approach of using a bougie to deliver a single lumen tube to the larynx is essentially very simple, but the same concepts at play here will be very useful when we discuss the much more challenging situation of difficult double lumen tube insertion into the trachea. Now, I emphasized a few minutes ago that the upper airway is narrow and short, and we will need to insert devices of different sizes into this cramped space. And clearly, it will be easier to manipulate smaller, slim items in this space than the larger, bulky items. So, different airway devices will have different degrees of freedom within this airway, and the degrees of freedom determine the options for a specific trajectory to the glottic opening. The slim intubating bougie, with many degrees of freedom in the airway, has several possible trajectories. The bulkier PVC endotracheal tube, and particularly double lumen tubes, have fewer degrees of freedom, and its trajectory will be much less predictable. And clearly, it's going to be much easier to manipulate a bougie into an anterior larynx than to manipulate a double lumen tube into the same anterior larynx. The degrees of freedom define that specific trajectory that an airway device can take through the short, narrow corridor we call the upper airway. The very reason we choose to intubate over a bougie is that the chosen stiff bougie can impose its trajectory on the endotracheal tube. Now, usually, the way things work is that the bougie imposes its trajectory on the single lumen or double lumen tube, but occasionally, the endotracheal tube imposes its trajectory on the bougie, and hence the flip-out phenomena occurs. Some trajectories will be satisfactory and lead to the glottis, and others will be much less satisfactory, delivering the device to the esophagus. In those situations where the relative stiffness and deformability of the chosen bougie and endotracheal tube combination are unfavorable, the endotracheal tube can impose its trajectory on the bougie, which is too floppy. And if excessive force is applied by the intubator, the flip-out phenomena is very likely to occur. So, avoid a combination where the endotracheal tube is stiffer than the bougie. Rather, always try to combine a stiff endotracheal tube with an even stiffer bougie. Now, of course, in the real world, most hospitals only provide a selected, limited range of bougies. Not every commercial bougie will always be available to you. But later, I will introduce some tips and tricks to deal with this situation in an accompanying video on difficult double lumen tube intubation over a bougie. All anesthesiologists understand that when using a Macintosh blade laryngoscope, the correct technique is to insert the blade on the right side of the mouth, then advance the blade in such a way that it displaces the tongue to the left. Although it is rarely stated, what we are doing here is taking advantage of a potential space between the lateral side of the tongue and the medial side of the molars, which I call the paralingual gutter. But note, this is purely my terminology. And there is an equivalent, of course, on the left side of the tongue. This gutter not infrequently causes significant problems for the anesthesiologist, so I've given this potential space a name simply for ease of reference. Consider this airway scenario number 3. This proceeds similarly to scenario number 1. A difficult laryngoscopy, resort to an intubating bougie, which is successful, mounting the ET tube over the bougie, successful intubation at first attempt, bougie removed, cuff inflated, tube secured, connected to the breathing circuit, and within a few minutes there is evidence of a breathing circuit leak. You attribute this to poor quality control by the manufacturer, allowing a defective cuff to leave their factory. So this defective endotracheal tube is exchanged over the bougie, and the scenario repeats itself 2 more times. Clearly, this is not due to a faulty product manufacture. What on earth is going on? The patient is reintubated 2 more times, a total of 3 intubations, until a smart colleague examines all these tube cuffs very carefully and detects tiny punctures and, in one, a linear rip in the cuff. 3 endotracheal tube cuffs punctured or ripped, and success was finally obtained on the 4th attempt. The mechanism is explained as follows. One of my anesthesia colleagues actually experienced this very situation, this phenomena, and it arises occasionally because the cuspids of the patient's molar teeth can be sharp, sometimes referred to as snaggle teeth. Unfortunately, during an intubation over a bougie, or over a fiber optic, or over an airway exchange catheter, these slim devices can settle in or very near the right paralingual gutter. And unless the position of the bougie or scope or catheter is changed, the endotracheal tube cuff is going to travel the same path and will predictably and consistently catch on these snaggletooth cuspids, and a tiny puncture or even a larger rip is going to occur with each and every advancement of a tube. Why should this occur? Well, during conventional direct laryngoscopy with a Macintosh blade, we nearly always introduce the endotracheal tube into the right side of the mouth. We do this under direct vision, and the intubator can see the tip of the tube and is careful to avoid obstacles like the patient's teeth. Now, in many patients, the mouth is a small, crowded place. When we are inserting an endotracheal tube over an intubating bougie, or over a fiber optic scope, or over an airway exchange catheter, we are essentially working blind. We do not see the exact trajectory of the tube over its guide. When the endotracheal tube is subsequently slid over the bougie, scope or catheter, the endotracheal tube does not follow the same trajectory as when we insert an endotracheal tube by hand. The endotracheal tube can slide through the paralingual gutter, which is immediately adjacent to the molars, and it's easy for some part of the endotracheal tube to make contact with a sharp cuspid, and this can lead to a slow, insidious leak or an obvious dramatic leak, manifest by total failure of the pilot balloon to support an inflation pressure. Consider this, airway scenario number 4, which happened to me some years ago. When working with an ENT surgeon or a dental surgeon, they may ask for the endotracheal tube to be repositioned to the left or right side of the mouth. A patient with a right-sided tongue lesion is having brief general anesthesia for direct laryngoscopy and tongue biopsy. During endotracheal intubation, the endotracheal tube entered the mouth on the right side, and after intubation, I moved it into a central position in the mouth, assuming it would remain in this position. But because the surface of the tongue is often convex upwards, endotracheal tubes may slide downwards towards one or other paralingual gutter. In this case, the oral portion of the tube had slid into the right paralingual gutter. The surgeon brought this to my attention. He said that the tube is now directly in front of the lesion he wants to biopsy, and he requests me to move the tube to the left side. I simply grab the visible part of the endotracheal tube, that is the external portion, the bit we can see sitting above the mouth, and I simply drag it sideways over to the left of the mouth. 10 minutes later, when the surgeon has repositioned the patient in some neck extension and is about to start the procedure, he announces to me the smell of volatile agent is coming from the patient's mouth. And I also notice that the tidal volumes are small, ventilators' inspiratory pressures are low, and there is clearly a breathing circuit gas leak. I check the pilot balloon, but it is at minimum effective occlusion pressure, and the endotracheal tube cuff, and pilot balloon system all seem to be entirely normal. What on earth is going on here? My intervention to move the endotracheal tube from the right to the left of the mouth was actually useless. Worse still, it was an iatrogenic complication because of my failure to understand the mechanics of what I had done. I had inadvertently partially withdrawn the endotracheal tube from the larynx. As I drag the visible portion of the endotracheal tube from right to left, the internal portion of the tube, which of course you cannot see, will often remain on the right side of the mouth, trapped in the right paralingual gutter. Thus, the tube has taken a very circuitous route, which is longer than it previously was. This maneuver actually pulls the cuff of the endotracheal tube slightly above the vocal cords, giving rise to a gas leak as the cords are pushed apart by the cuff. The best way to move the tube from one side of the mouth to the other is to insert your index finger deep into the mouth to the right of the endotracheal tube as far as the base of the tongue, and gently perform a right to left finger sweep across the base of the tongue, pushing the endotracheal tube to the left side of the airway, where it can sit securely in the left paralingual gutter. This avoids partially pulling the endotracheal tube out of the larynx. Scenario number 5. In ENT and dental surgery, requests for nasal intubation are frequent. And for some oral surgeries, ENT and dental surgeons often need to hyperextend the head and neck to maximize mouth opening. After the normal conduct of induction of general anesthesia and either an oral or nasal intubation, a breathing circuit gas leak is again detected. Because the nasal airway anatomy is relatively narrow, the intubator often tries to be kind to the patient and avoid epistaxis by choosing a small, narrow endotracheal tube, such as a size 6 internal diameter cuffed endotracheal tube. This may be very satisfactory for short adults, but in normal or tall adults, a size 6 endotracheal tube, which is only 28 to 30 centimeters long, inserted nasally, will frequently result in an air leak, and this is worse the more extreme the neck extension. This is occasionally misdiagnosed as an endotracheal cuff leak, but it occurs as the upper border of the cuff, the shoulders of the cuff, rise above and push apart the vocal cords, and this is the origin of the gas leak and gives rise to the smell of volatile agent in your surgeon's face. And the gas leak gives rise to loss of minute volume. You must recognize, of course, that the endotracheal cuff remains blameless. It's fully intact. The worst case scenario is that you may need to change the endotracheal tube to a longer device, such as a size 7 millimeter internal diameter, 30 to 34 centimeter long endotracheal tube, depending on the height of the patient and the degree of neck extension. So the problem here is that in our attempt to be nice to the patient and use a nice narrow tube, we were automatically choosing a tube that was also shorter, that is, too short, for all but our smallest adult patients.